Hi, good afternoon. I'm Grace Mack, representing the Education Committee, and we're getting ready to start our Variations in Care session. So we're going to be talking about today primary anastomosis versus early stoma closure for babies with either NEC or SIP. And so this is our lovely panel and moderators, and we don't have any disclosures. These are our objectives, which are also in your WOVA app. So one thing I did want to ask everybody to do is to go ahead and log into your WOVA app, because there are going to be some polling questions that we're going to be going through. And then we'll go through the results more towards the end of the session.
All right, so if everybody could get their phone out, because I think the poll questions are going to be really key. It's going to lead to some provocative discussion, hopefully at the end of the session. So if everybody can get on there, click on the polls section. I think they're a little out of order, but this is the first question, and so we're going to go through a few scenarios, and then we'll circle back to these at the end, and it'll promote some discussion. So the first patient is an 8-year-old X28-weeker born at 1,100, who's 1,100 grams right now. He develops abdominal distension 4 days after starting his feeds. An initial abdominal X-ray shows pneumatosis, but the following day the base XS is -12, platelets are 40, and a repeat abdominal X-ray shows a fixed bowel loop in the right lower quadrant. Baby's now on dopamine at 12 mics, ventilated on IMV with an FiO2 of 0.5. Based on that, whether you would or not, you take the baby to the OR and you find 20 centimeters of necrotic mid-ileum. The remainder of the small bowel and colon, you're confident, looks healthy. In the OR, the dopamine's able to be weaned down to 3 mics. The platelet count's 130 after a platelet transfusion. So at this point, you would resect the necrotic ileum and clip and drop the 2 ends and return for a second look in 2 days. Anastomosis the ileal segments right there, create an endoileostomy, or create an endoileostomy with a mucus fistula. Unfortunately, we don't get to see the results right now, but Grace and Mike are going to report them at the end, so you get to see what everybody did. This is a little bit of a alternative view. So alternatively, you find an additional segment of bowel totaling about 60 centimeters that appears compromised, but it's not clearly necrotic. You're not ready to resect it. So you resect the 20 centimeters of necrotic bowel that we saw before, leave the bowel in discontinuity, put in a wound vac. 2 days later, you come back, the baby's off pressors on minimal vent settings, his platelet count's 200, looks good. So at this take back, the areas of concern that you had before, they're now pink, well perfused. So at this point, you would wash out the abdomen, return for a third look in 48 hours, anastomose the ileal segments right there, create an endoileostomy with a mucus fistula. Now changing gears, so for NEC cases where you do resect bowel, if that's what you do, and place a stoma, you typically would do a stoma takedown when the baby's 2 kilograms and 6 weeks post-resection, at 6 to 8 weeks post-resection, regardless of the weight at that time, just prior to discharge from the NICU, or electively after discharge from the NICU as an AM admit. And then the final one, dealing with something that's not NEC, you have a 2-day-old X30-weekers, 1,500 grams. They develop abdominal distension, otherwise looks stable. They get an X-ray that shows a massive pneumoperitoneum. Since he's over 1,000 grams, you elect to take him to the operating room rather than placing a drain. You find an isolated 3-millimeter perforation in the ileum with just some adjacent meconium. The baby's doing well in the OR. What would you plan to do? Resect, create a primary diverting stoma. Resect, clip and drop the 2 ends, return for a second look. Resect with an anastomosis, or do a primary closure of the perforation without a resection. So while you're collating all those, we'll go into a little bit of a background of this, this issue, if we can. The slides are not advancing. Is there any control of that from there? Oh, there we go. So this has been a debate that's been going on for over 60 years. So in the mid-60s, when NEC was well defined as a surgical disease, Dr. Talukian and Dr. Santulli recommended after resection that a chimney type of side-to-end anastomosis be done, saying that this is considered the preferred procedure as it allows for early occlusion of the stoma, thereby minimizing the loss of fluid and nutritional complications. So early on, there was some recognition of the downside potentially of a stoma. But within 12 years, there was already some blowback to this as being dogma for what to do. So Dr. Kieswetter said in selected cases, areas of bowel that have good perfusion, no pneumatosis, minimal edema or distension can be anastomosed without complications. So this is in 1979. the same year that in the adult world, the dogma of mandatory proximal diversion for penetrating colonic injuries in adults was being challenged. And based on this, these authors said in the results from the present prospective randomized trial of truly equivalent patient groups, there is support for the practicality of selective primary closure of traumatic colon perforations. Now, while this isn't directly analogous to what we're talking about today, in the adult world, at least a decade and a half later, things went pretty much away from proximal diversion with traumatic colon injuries. So where do we stand contemporarily with the use of primary anastomosis in NEC in 2023? So BAPS did a study of all the UK children's hospitals a few years ago and found that in 17% of cases, a primary anastomosis was done in NEC. In the US, we actually did a FIS study over a 5-year period from about 2016 to 21, and then very similarly, 14% of patients were managed with a primary anastomosis after resection. About 50% of hospitals did at least one primary anastomosis, so 50% of them never did it. And the patients who did get a stoma, since we're going to discuss that as well, almost 2/3 of these stomas were done on a subsequent admission as an AM admit, not during the initial NICU course. And the median time to stoma closure was about 80 days. So with this in mind, let's recognize that whatever bias you may have to what you might want to do, there's certainly a lot of nuance that needs to be considered in the operating room when we're making decisions based on the appearance of the bowel, the degree of contamination, the baby's hemodynamic and respiratory stability, their weight, the length of bowel that you have to work with, the length of the operation, how long you think it's safe to be in the operating room, the status of the colon distally, especially if you're doing an anastomosis as far as concern for later stricture development, and whether you might consider a staged resection, and that might make you more likely to do an anastomosis. So as we listen to the two debaters, these are the considerations that they'll talk about and we should think about as far as outcomes. The cost, the issue of stoma complications, which is a real one, and the contrary concern for anastomotic leak or anastomotic stricture, and then issues of nutrition and electrolyte loss, how they might be impacted by your decision. Issues of parental stress, particularly with the stoma and going home with that, the concern for having to do a stoma takedown as a second or third procedure, and then finally concern for a late stricture for unrecognized colonic disease that you had after you did an anastomosis. So Mike Livingston now is going to introduce our debaters, and after that we'll come back, see how everybody answered the questions, and then get hopefully a good amount of audience feedback and stir up some provocative discussion.
Thank you there, Dr. Livingston, for revealing my age. So I'm biased. I was asked to be biased. I was asked to debate on the side of stomas. How do you move the slides along? F, that's what I tried to do. So taking the side of the stoma around 3 questions. What does the literature say? So we'll start with that. So this was a systematic review actually done by our very thorough and competent ABSA's outcome committee about 10 years ago. They looked at 10 only retrospective studies and could not conclude to make a case in favor of doing an anastomosis over a stoma at that time. This is another study that was published about 4 years later, I think 2016. It's a study out of Barcelona, and they looked at, it's a one institution study. The patients included are only spontaneous perforation patients, no neck patients who are excluded, and even by selecting often the less sick babies with SIP as opposed to neck, they found significantly higher, more serious complications in the group that had had an anastomosis, including increased rates of death. And then the last study I'll bring up is another systematic review done by the group in Ottawa, where they didn't find any difference in complications in that study. Also, I will add, composed of retrospective studies only, but they did acknowledge that the mortality, the patients who were selected for anastomosis were likely less sick, than the patients who were selected for a stoma. So a pretty big selection bias there. And so the last sentence of the paper actually says that there is no support existing in the literature to select one strategy over the other strategy. So, based on the existing literature, I do believe that a stoma is the safest approach in the majority of patients. Second thing I was asked to think about is when would I consider doing a primary anastomosis? And so I would ask myself and my very good fellow and colleagues, of course, to think about some patient factors and some disease factors. So how stable is the patient? Could they tolerate another operation if they needed one? How proximal is the stoma? What kind of output? And where I've been practicing for the last 15 years at McMaster, where we use refeeds a lot. So stoma, mucus fistula, refeeds that often allows us to get off TPN. So that would be another question I'd ask myself, is refeed going to be possible? And based on, you know, the sum of these questions, I think I would consider doing a primary anastomosis in patients with SIP who are stable, particularly if the perforation is proximal and you're going to have a high output stoma, and in some circumstances, perhaps where refeeds wouldn't be possible. And then just finally, when should patients who have a stoma have a reversal? So interestingly, after I relocated from McGill to McMaster 15 years ago, we joined forces between my new colleagues and my old colleagues, and we did that study on stoma reversal. We had about 80 patients, which was quite a high number for this kind of study. And what we found was that in the patients had an early closure. They were ventilated for quite a bit longer. And I'm going to say we still have a unit where we struggle with getting our babies off the ventilator. We don't have access to IV Tylenol to decrease the narcotization. That was true 15 years ago. It still is true. And perhaps as a result of that, or in combination with other things, our kids who were reversed early took longer to get off the vent, longer to get off TPN, and longer post-op to get on enteral feeds. So our conclusion from that study was that unless you had a really good reason to, it was probably better to wait until later to reverse the stoma when perhaps they wouldn't have as much SIRS and be extubated sooner, etc. But I acknowledge that that study is dated, and there's more recent information from the Toronto group that found no difference really between early and late closure. So I consider closing a stoma early if the patient cannot get off TPN. And in our institution, that really is often when refeeds are not possible. If there's complications relating to the stoma itself, like prolapse or retraction, or if there's a lot of problems with skin and keeping an appliance on, etc. So I will now give it back to Dr. Livingston to introduce Dr. Zani, and thank you very much for listening.
Thank you, Dr. Flajol. I now introduce Dr. Augusto Zani. Dr. Zani is an attending surgeon at the Hospital for Sick Children in Toronto, as well as a scientist at the Sick Kids Research Institute and associate professor of surgery at the University of Toronto. He completed his pediatric surgical training in London, UK, and earned his PhD from University College London, United Kingdom, where he investigated stem cell therapy in necrotizing enterocolitis. In 2014, he moved to Toronto for a fellowship in neonatal surgery, and he joined Sick Kids in 2016. His lab is actively involved in studies focused on NEC and CDH, and he was selected as a Grossfeld Scholar by the APSA Foundation in 2021. Welcome, Dr. Zani.
Thank you. Thank you very much for the very kind introduction, and thanks for inviting me to share some thoughts about something that's very close to my heart, like necrotizing enterocolitis. I don't need to convince you, of course, that this condition is still burdened by high morbidity and mortality rates, especially for babies who require surgery. We still don't know which one is best, and there's not one-size-fits-all kind of approach. Both primary anastomosis and ostomies work, but they also may be associated with severe complications. There's been a lot of research, well lab research on NEC, but there's no reliable model that can give us an answer on what is the best approach for our research question. How do I go ahead? Now I understand it.
Yeah.
This one?
Yeah. Okay.
F.
There you go.
No, that's...
There we go.
Okay, so we all know that NEC was first described by the group at the Babies Hospital in Manhattan, and originally, initially, very high mortality rate. And of course, these babies being premature in the 60s, 70s, it made sense to, of course, advocate for resection and an ostomy formation. And there's this nice paper from Dr. O'Neill a few decades after advocating against an anastomosis. But not very long after, the dogma started to be challenged, and as you can see from this paper that has just been also mentioned, there's a possibility maybe in selected cases with clearly demarcated disease and good tissue perfusion, there is a possibility to consider a primary anastomosis. And then there were other papers from Houston, Texas, Great Ormond Street in London, again challenging the dogma. Now, obviously, a primary anastomosis saves the baby the risk of metabolic derangement, avoids a second surgery and therefore a second GA, and reduces the wound area with potentially reducing the risk of SSI. When you look at potential complications from performing primary anastomosis, it's mainly the leak, the stricture that we've, of course, heard about and we all know about. All the other complications are more or less shared with the same rate with the ostomy formation. So when we don't know what to do in the era of evidence-based medicine and surgery, we go to our usual tools, systematic reviews and meta-analysis. And this has already been, in fact, shown by Dr. Flagiol. The group in Ottawa looked at primary anastomosis versus ostomy formation. Didn't find any randomized control trial, found 12 comparative studies with a few hundreds of patients in each arm. And they found a difference in mortality that is favors primary anastomosis, but there's a clear bias there because the babies that were sicker for sure were going more towards the ostomy formation, no differences in complications. And so wisely they concluded that there is limited evidence in the literature and there's, without sufficiently powered randomized controlled trials, no suggestion can be definitely made regarding the choice to make. So I'm excited to give you a flavor of a study that whose analysis is just recently being completed, the STAT trial, that stands for Stoma versus intestinal anastomosis for NEC. This was a multi-center randomized controlled trial designed and coordinated by Dr. Agostino Piero, who's here in the audience. The study was powered for 80 patients, 14 each arm, and used weighted minimization. So it means that when we were operating the babies, we would do the laparotomy, assess the bowel, and then look at the areas of the bowel. And of course, then unscrub, go to the computer, and randomize the baby. And you can see the minimization criteria. There's the weight, mechanical ventilation, and inotropic support, extent of the disease, and the segment of intestine that was involved. primary outcome being the duration of parenteral nutrition and a bunch of other secondary outcomes. Well, I think the biggest success of this trial, as for any trials conducted in pediatrics, is that we managed to recruit all 80 patients that the trial was powered for. It took a long time. What the conclusion of the trial is that there's a short duration of parenteral nutrition for patients that are having a primary anastomosis, and this was significant. But there were no significant differences in mortality or complication rates. So in my opinion, primary anastomosis should be considered as laparotomy for NEC when there is no disease distal to the resected intestine. Of course, we need to consider also the stability of the patient, whether we are talking about the classical necrotizing enterocolitis and not the cardiogenic NEC. So there are other factors to take in consideration, but I think it's a feasible and safe option for these babies. Thank you.
And so now we're going to go back to our original polling questions. So question 1, the question was basically for a NEC baby that has about 20 centimeters of necrotic ileum, what would you do? And so the results, the great majority chose D with 54%. 54%, creating an endoleostomy with a mucus fistula. Next was C, create an endoleostomy with 17%. Oh, just kidding. That's number 3. That's 17%. Number 2 was actually clip and drop, the 2 ends and return of the second look in 48 hours A. That's 19%. And then answer B, anastomosis, the 2 ileal segments, was 11%. And so now we wanted to give our 2 debaters, I guess, time to comment on what they would do for question number 1.
Okay. Well, full disclosure, I wasn't aware of the STAT trial until now, like probably most of us. I think it's fascinating. I was going to ask Dr. Zani if I may take the privilege of the microphone. Did you use refeeds at all in the patients who had an enterostomy? Because your main conclusion was shorter time on peripheral nutrition, so I'd be very interested in knowing the answer, whether or not you used refeeds.
Thanks for the question. No, we don't tend to refeed the distal limb in babies with NEC. It's different for the ones who have short bowel syndrome and they're older, but we don't do that in our babies, in our cohort of babies with NEC.
So then in response to this question, I think I'm going to say, after I read the paper, and, you know, I think it's a good paper, I would maybe consider doing an anastomosis, but I have to read the paper first.
And then if any of the audience wants to come up to the microphone as well as we're going through these questions, please do, because obviously we want to kind of keep this open for discussion amongst the group. You want to go?
I just very quickly say I would do a primary section and anastomosis, but I see Dr. Hackham, and so I'm...
Thanks, David Hackham from Johns Hopkins. So what a great panel, great discussion, and kudos to the program committee for doing this. And I think we have to be honest that we actually, even though all of us know what to do, none of us really know what to do. And those of us that have been doing this for 20 years really know what to do, but still we have to be honest that we must make the commitment to ourselves, to our field, and to our patients that we want to practice differently in 5 years than we did 10 years ago. That said, there are just a couple of things that I'm just wondering if the panel would comment on. The first is in terms of outcomes. I think all of those were really important outcomes that were described, stricture, leak. But there's 2 other important outcomes that I think are important. The first is neurological dysfunction. We're learning that in patients with NEC, there's a significant risk of neurological dysfunction, and it's probably linked to the extent of bowel, and it's certainly linked to the extent, to the age at which surgery is performed. And surgical NEC does worse than medical NEC in terms of neurologic dysfunction. And one of the indications for early surgery in NEC, I think, should be the brain, and we have some data in support of that. So I'd be interested in whether a faster operation that gets the bowel out and brings the stomas out versus a longer operation in a child that may then suffer one of these complications, may not just have an abdominal problem, but a secondary neurologic problem. And I'm wondering if you could factor that in. The second thing is recurrent neck. Now, this is probably tied to the feeding pattern, and you might argue that an early stoma reversal, which I advocate, might create the same issues with recurrent neck than if you've got an anastomosis in there. But we do know that the risk of neck after feeding really doesn't go down to zero until post dates, until you reach sort of term. And so as we contemplate an anastomosis in an otherwise stable child, we have to realize they may have 4 or 5 weeks where they're still at risk for recurrent neck, which if there's an anastomosis in there may be a bigger deal for obstructions, bowel loss, etc. And the final thing I would say is I think that the management of neck is going to change in the next 5 to 7 years because of the work from Gail Besner, from Kathy Hunter, from Agostino, from our group. There are new insights, new understandings, many of which are being presented at this meeting, and I apologize for those whose names I forgot. But I think that if we can treat neck as a combined medical surgical disease, if we can use biologics to interfere with those pathways, and if we can combine manipulation of the microbiome, then these negative outcomes associated with earlier anastomosis or even anastomosis at the time of surgery can be minimized. And so I think updating our surgical approach has to occur as we update our medical approach. And I think this type of a conversation allows us to do both. So kudos to the committee. I'd be interested in your thoughts on those comments. Thanks.
I could just comment briefly. Those are really thoughtful comments coming from you, especially. I mean, one consideration that's very important to me, and I mentioned, was length of the operation. And I don't know about you, but I've had good success with using a stapler for anastomoses, even in the smallest babies using a 5mm just right. And I feel I can do that just about as quickly as a stoma, and that eliminates that extended 45 minutes, which might be really key to neurodevelopmental outcome. Have you had any experience with that?
Yeah, no, I wanted to say thank you for for the thoughts, and of course I do believe it will change in the future, and even after surgery, the biologics and all the other compounds that have been studied could be useful to regenerate the damaged intestine. I do believe that neurodevelopmental impairment is a big issue in neck, and in fact, of course, you published great work. We also reported the neuroinflammation in the brain. I think the question is, for me, the length, I don't see so much of a difference if the baby is stable. I think we need to resect the bowel. So we are already beyond the usual dilemma, drain versus laparotomy, and I don't want to go there. But I think it's important to resect the bowel. This is necrotic. It's the one that is causing this cytokine storm that, of course, affects these babies' brain. But I don't think that an extra, 20 minutes, half an hour for a baby that is stable would actually necessarily have an effect. And for the stoma, I agree with you. When to close it, there are babies that I think are very safe when 6 weeks after the surgery. Of course, they need to be studied to exclude strictures. We don't need to wait for too long. It's not just a matter of costs, but also to establish bowel continuity for all the aspects that you also mentioned, including gut flora.
That's great. Thanks.
So technically we are out of time, but I think we were given permission to go a little bit long. So I think you were next, sir.
Hi, David Rothstein, Seattle. It's always folly to follow Dr. Hackham, but here goes. Would the panel members comment on the idea of using ICG intraoperatively to examine the health of the bowel? And then secondly, would anybody be interested in a trial to look at mini laparoscopy the next day if you choose to do an anastomosis to look at it before it falls apart? Thanks.
This is a great idea. We used it in the past for gastroschisis bowel and to look at whether it was compromised, but it's maybe something to look into.
So, Mark Wilcon, Akron, Ohio. So my question, I guess, follows a little bit up on what Dr. Hackham was asking about. And When you look at the added morbidity of the stoma closure and the possible neurodevelopmental impact of that second anesthetic, does that change your calculus on which way you should go?
Well, I think we're all aware of the papers, although there's not super hard evidence about the effects of the anesthesia again on the brain. So I think in my that's something that I consider, and I want to avoid a second anesthetic.
Yeah, I think it's the anesthetic, but it's also what happens post-op and the need for, opioids and ventilation and SIRS. And I've seen in terms of stoma reversal, sometimes you choose to close it early because of outputs or stoma issues. And what should be a very straightforward operation, and typically would be in an older infant, a very young one will have quite severe SIRS and end up, with a lot of medical support for days. And I think that also contributes to the poor outcomes. It's not just the hour or hour and a half long general anesthetic. I think that's an important factor too.
Dave Nitriga, Phoenix. I'd caution not quite so fast on doing a stable anastomosis on newborns. I have operated on one patient at 7 years and another at 10 years out after stable anastomosis, where the end-side anastomosis was the lead point for a volvulus. So now they were not done with the Just Right stapler; they were done with conventional staplers. But I do think that there's an opportunity to study that before we start talking about doing it at wide scale.
Greer Arthur, New Brunswick, New Jersey. I agree with a lot of what Dr. Hackham said, and he probably has forgotten more about NEC than I'll ever know. But I sort of feel like the key about when you can do the anastomosis is if the SIRS response is gone, right? And so if you have a SIP patient that is really healthy and looks good and everything else looks good, it looks like that would be a case where in an older kid we could do the operation and we don't worry so much about anastomotic strictures. For NEC, I've done several cases where we've just done the clip and drop technique, put a wound vac on, and you sort of minimize the procedure. You can get it. I try to get my procedure done in a half an hour if I can. And so you're minimizing the general anesthesia. And then if you change the wound vac a couple times and come back 5 or 6 days later, you can actually put them back together. Now they're off pressors, their platelets are stable, and you can get away with that without having the long-term complications with an ostomy. So that's just how I've kind of adapted my own practice, and that's, I wonder if that'll.
I think the audience agreed with that. Is that right, Grace? If you report the poll results, that after that 48-hour period, dropping it in, it sounded like more people, maybe twice as many, were willing to do an anastomosis?
Yeah, so actually, that was question 2, and then we'll do our one last comment. For question 2, 54% of people at that point said they would still do an end ileostomy with mucus fistula, so option D. 32% now said they would do a primary anastomosis. 9% would do the end ileostomy, and 4% would do the washout. So little shift, but still 54% said an ileostomy. Sir, left.
I just have a short global comment. Sharif Emil from McGill. We participated in the STAT trial. It was exceedingly difficult to randomize patients. Augusto, so I'm happy it was finally completed, but I'm not surprised it took a decade to complete. This was a really civilized debate because we really don't know, as David mentioned. But I think it really points to the difference between judgment and evidence. And sometimes we just have to admit that we don't have the evidence. And so judgment really becomes an issue of rationality and experience. So it is rational in a baby with NEC who is hemodynamically stable and has a focal segment to do a primary anastomosis. That is a rational decision. And if that anastomosis stenoses or leaks, that is a complication we accept. But the decision was made correctly, even if it did not end up being the correct decision, as one of my colleagues often says. But if you're operating on a 2-day-old who has a very focal, small perforation, and the sutures are not holding because the bowel is like wet toilet paper, it is irrational to do a primary anastomosis. And that's where judgment really comes in. The trouble I have is dogma. You know, when a surgeon says, I'll never do a primary anastomosis for neck, or I'll never close a spontaneous intestinal perforation. I think there is where you're denying some patients potentially a better outcome. And I would just encourage all of us to try to always be less dogmatic and, you know, take every case for itself.
Okay. I think that was great. Yeah. So you should be able to see the rest of the polling results. Oh, can't see it. Okay, so then question 3, just to go back really quickly, the majority of people will close early, which is part of this discussion. So 59% would close at 2 kilograms or 6 weeks. 27% of people said at 6 to 8 weeks. And then 4% prior to discharge and 10% after discharge. And then lastly, question 4. You can just read yours.
So the majority, 41, not majority, but the highest number was 41% that chose B, resection and clip and drop. Oh, wait, hold on. Oh, no, 41%, sorry, chose, oh, that's why it has ABB. Oh. Because I was like, they only gave us 3. We're just going to keep going. So question 5. Sorry, y'all.
Just to close, if everyone could just answer question 5 for us. If this session changed your thoughts and potential practice about performing a primary anastomosis, if you're more likely to do it in neck, or you're more likely to do it in SIP, if it didn't change your opinion at all, and then if you're less likely to perform in either neck or SIP. And we knew this 30 minutes would go very fast, so thanks for staying longer with us, and thank you to the panelists.
Thank you.